This is a story. It's a story of 25 years of state health policy. It's the story as I tell it. Others might tell it differently, but I get the opportunity to do it today. Of course, we were formed in 1987, but there are a few events prior to that date that are worth looking at to set the stage. Here is Franklin Roosevelt signing the Social Security Act in 1935, a few years before NASHP was founded, but it certainly sets the stage for social policy in this country and the platform on which many of the programs we work on was built. We move into the 20s, 30s, and 40s, and two different mechanisms for financing health care emerge in this era, both of which we confront and work with today. On the one hand, Blue Cross offering hospital coverage, Blue Shield offering physician services, creates a robust market for private health insurance, paying basically on an indemnity basis for services used. But in the same era, we have Henry J. Kaiser hiring doctors and building a hospital to treat his steelworkers and trying to maintain their health and prevent them from getting sick so they can be more effective workers. The precursor, of course, to the Kaiser health plan that we know today. And so even back in the 30s and 40s, we see the elements of evolution of the healthcare system as we know it today. In 1945, Congress passes the McCarran-Ferguson Act, which has the federal government withdraw its potential oversight of health insurance and other insurance and leaves the field to the states, setting the stage for the insurance regulation and all of the insurance issues that we confront being handled at the state level as opposed to at the federal level. And as a lawyer, I can't help but note that in 1964, the Supreme Court ruled in the case of Reynolds v. Sims, stating the principle of one person, one vote. You may not know, but before that case, many state legislatures were like the United States Senate, one member per county, and you would have a county with 200 people represented equally with a county with 20,000 people. And Reynolds v. Sims said that's a violation of the United States Constitution. And it fundamentally changed the composition of state legislatures and moved power back to urban areas that were growing at the time and made those institutions much more directly representative than they had been. And then, of course, in 1965, Harry S. Truman becomes the first American to receive a Medicare card. We launch an era of new programs serving Americans. What's striking, of course, in the creation of Medicare and Medicaid is that Medicare is a uniform national program, but Medicaid is not a uniform national program. It's not just that administration is left to the states, which of course differentiates it quite a bit from Medicare, but of course states set their own eligibility levels and they tie those eligibility levels to welfare, and so Medicaid begins as a program fundamentally tied to welfare and state differences in their views about welfare state, about the welfare state and welfare programs and the generosity of those programs, and that is a theme, of course, that plays out over the years, the differentiation between the uniformity of Medicare and the state variability of Medicaid. In 1972, we make additional amendments to the Social Security Act establishing the SSI program for the aged, blind, and disabled. Of course, this is a cash assistance program, but it brings with it Medicaid eligibility. And although we know that most people on Medicaid are moms and kids, over time, this population has grown to dominate the spending on the Medicaid program, and we trace our roots back to, in 1973, we have the Federal HMO Act requiring large employers to offer an HMO product to their employees if they offer health insurance. And in 1974, we have ERISA, the Employee Retirement Income Security Act, which is mostly focused on retirement, but has this seemingly small provision preempting state laws that regulate employer benefits that comes to have a tremendous effect on the evolution of state health policy. So finally, we get to the incorporation of the Center for Health Policy Development, which is the corporate parent of the National Academy for State Health Policy, and leaders from around the country come to Denver for the first NASHP meeting, and thus our story begins. So that's where this NASHP story begins in 1987, 88 as we started. Ronald Reagan was the president. We were watching The Cosby Show. And we were listening to I think I saw some NASHP staff in that video. The economy was strong. That's GDP, real GDP growth each year, and in the early years we were seeing 3–4% real growth, which is pretty good. The economy was healthy, and 1987 was an auspicious time to form NASHP because it was the first year that the Census Bureau announced the number of people without health insurance. And much to the surprise of many, almost 13% of Americans, 31 million people, were lacking health insurance. National health expenditures, 11% of GDP. Sounds kind of quaint today, doesn't it? But the uninsured numbers, we learned, were growing even as the economy was strong. And it gave a sense that there's something wrong here. This is not a problem that's just going to go away through economic growth. And so as NASHP was formed, we were really clearly in the era of incremental reform. So what did the federal government do during this period of incremental reform as we as a country came to understand the problems that we faced? First of all, the federal government started paying attention to moms and kids. We had OBRA of '87 providing the option to cover pregnant women and children at the state level through their Medicaid programs in '89. Some of that coverage became mandatory. In 1990, we started phasing in coverage for poor children. So the federal government puts its focus on the most vulnerable, the lowest income, but it also, way back then, realized that we had all these seniors who didn't have prescription drug coverage. And so in 1988, we enacted the Medicare Catastrophic Coverage Act, and we saw this.
He's supposed to represent the people, not himself.
Once inside the car, the congressman could go nowhere for a few minutes as the crowd surrounded it. Finally, Rostenkowski got out of the car and walked down the block, diverting the crowd away from the car.
I don't think they understand what what the government's trying to do for them. It's a problem, but it's always been a problem.
You sympathize with their anger on this?
No, I don't think they understand what's going on.
Okay, this is before the internet and YouTube. So those of you who were around at the time, this is seared into your memory. Those of you who weren't, you probably have no idea what that was all about. So let me tell you what it was about. The federal government said we're going to extend coverage to prescription drugs in the Medicare program. We're going to place some limits on out-of-pocket costs for low-income elders on the Medicare program. It was paid for through an increase in payments by those higher-income Medicare beneficiaries, and they didn't like it very much. And you may not have heard, because the audio, this is, old tape here, but you may not have heard Congressman Rostenkowski saying, being asked, do you have any sympathy for these people? He's like, no, they just don't understand what's in the law. Does that sound familiar? Indeed, a piece was published in Health Affairs by Tom Rice and colleagues. They did a survey of elders. What's most noteworthy about these responses is the very low knowledge level exhibited. 2.4 out of 8 questions was all the average senior could get right about what the characteristics of the law were. It was, of course, repealed a year later, something that's almost unheard of in American social policy, with small amounts of the law retained in place. And of course, as you know, it took almost 20 years for the federal government to finally enact Part D in a way that stuck. So it's not that we were unaware of these problems, but the politics and the sense that people just don't know what's best for them, these things are not new. During this incremental period, we had a lot of new efforts at the national level, looking at a broad range of programs. We created transitional medical assistance supporting people leaving welfare so that they would have health benefits. The Ryan White Care Act was enacted, providing coverage to people with AIDS after a student was prevented from going to school when he was found to be HIV positive. We had the Breast and Cervical Cancer Mortality Prevention Act, which brilliantly provided screening for breast cancer and cervical cancer, but of course no access to services to treat them if you were found to have them. That took 10 years for us to adopt. We developed the Vaccines for Children's program after a measles epidemic spread through the country. What's striking about all of these programs is that they built on a Medicaid platform because the country didn't have any platform other than Medicaid to build on when it wanted to do something. So whether it was coverage for people leaving welfare, whether it was providing vaccines to low-income families and children, you'd look around and say, how do we do this? Well, add it to Medicaid. And so we continued to build off of the Medicaid platform, adding categorical eligibility category after category, filling in needs, leading, as I wrote about Medicaid a decade ago, to call it the workhorse. I think we've seen it over all of this period. Now, it wasn't primarily a health piece of legislation, but this is also the period of the Americans with Disabilities Act, which of course comes into play somewhat later. So this is what the federal government is doing during the incremental build. What are the states doing? Well, of course, ask NASHP. Who's the author there? Oh, Trish Riley. That name's familiar. And Barb Yondorf, the Flood Tide Forum, Access for the Uninsured, lessons from 25 years of state initiatives. And it's really an amazing story. And of course, I can't tell the whole story, but I hope to be able to tell enough that you have a sense of what was going on during this period. So first of all, states are implementing the OBRA legislation. But they don't just take up the federal government's offer to provide coverage. They go well beyond it. 39 states go beyond the federal minimums when it comes to coverage for pregnant women and children. And state after state looks at OBRA as a platform and says, how do we go further? So Vermont, as Trish mentioned this morning, creates Dr. Dinosaur, which is much broader. Colorado creates the Child Health Plus program that relies, get this, on gifts, grants, and donations. That's an innovative source of funding for health programs that many states have learned to use quite to their advantage, but it's not a traditional Medicaid program. Florida creates the Healthy Kids Corporation and builds kids coverage into the schools. Pennsylvania enters into a partnership with the Blue Cross Blue Shield program in that state, and they become the template for the CHIP program adopted years later. New York stretches the limits of children's eligibility, again, a time-honored New York tradition. So we have all these states saying, okay, it's the time to move forward, we're going to move forward on kids. We also had states working on health insurance reform. As, again, was alluded to some this morning, the building out of high-risk pools, use of purchasing pool subsidies to small employers to encourage them to provide coverage to their employees. We had guaranteed issue limitations on pre-existing condition exclusions, big fights all over the country around how to make the health insurance market work better for people. Many protections adopted in the small group market, fewer in the individual market. And in many states, insurance market reform became sort of the conservative alternative to expanding public programs, with the idea that insurance market reforms have one huge advantage. They don't have any public treasury costs. You're just regulating an industry differently, whereas, of course, coverage expanses have some dollars associated with them, and so they became a battleground. But we also had a few states really out in front looking at much broader reform initiatives. So Washington creates the Washington State Basic Health Plan, providing a Medicaid alternative to low-income families up to 200% of poverty. Oregon tries to expand, does expand, and goes through a waiver negotiation to expand Medicaid up to 100% of poverty. And Massachusetts leads the way in 1988 with the Massachusetts Health Security Act, signed into law by then Governor Dukakis. It provides for an employer pay or play, where you either provide coverage or you pay a tax. And it's designed that way because ERISA prevents states from mandating coverage, and the pay or play model is thought to fall outside the prohibitions of ERISA. The question of whether or not that would withstand scrutiny is never answered because the law is delayed and ultimately repealed in 1996. So we have this period of incremental expansions, the federal government doing a lot to expand insurance reforms and a few states leading the way. And so this era of incremental change comes to a close, and George H.W. Bush is now the president. We are watching, cheers, and listening to.
Don't you know, things will change, things will go your way, if you hold on for one more day.
All right, don't get up and dance. If you're going to get up and dance, dance to walk like an Egyptian. All right, so the economy now is having a rough spell, and we're in a downturn. It's short relative to the one we've just are trying to dig our way out of, but it does slow everything down. Yet, of course, despite the fact that the economy is contracting, briefly, the number of uninsured grow, not surprisingly. Health expenditures grow as a share of GDP. And we've at least found one thing we can all agree upon, which is that healthcare costs and the number of uninsured will grow no matter what, whether the economy is good or bad, no matter who is in charge of the government. And so this period of incremental reform comes to a close as we enter the era of comprehensive reform, which I mark with the campaign and election of Harris Wofford in Pennsylvania, who comes out of nowhere and beats the popular and quite moderate former governor, Republican Dick Thornburgh, on the slogan, "If criminals have the right to a lawyer, I think working Americans have the right to a doctor." And Democrats, in particular, of which he is one, realize that they have a winning issue, and that issue is health care. And I will say that I was working for a Democratic governor at the time, and the polling numbers that we were shown, one of the common tests that pollsters do is to do what's called the gap between who you trust more on an issue, and, defense has historically, traditionally been a Republican strength, deficit control, economy, and the like. The pollsters told us they had never seen an issue with as large a gap between Democrat and Republican as health care. And so Democrats said, this is our opportunity, we're going to run with it. Now, of course, Harris Wofford is elected before President Clinton, and in this early era of comprehensive reform, we see states continuing to move forward. We see Vermont build on Dr. Dinosaur and approach a universal access bill looking at single payer. Funny, Vermonters just can't shake that single payer idea, can they? And we see Minnesota building Minnesota Care and expanding it up into the middle class to 275% of poverty, building a separate infrastructure for coverage that goes far beyond the traditional welfare eligibility levels. And so states are moving forward, and of course, we skipped Bill's picture, but there's President Bill Clinton elected in 1992. Americans were watching Home Improvement and listening to. So I think when Bruce said the music was better in the 80s, he was certainly right. The economy has picked up steam, and it stays strong for quite some time. But again, the number of uninsured has now exceeded 15%. National health expenditures are continuing to grow, and we see an explosion, truly an explosion of activity in health care. We move into an era of active granting of waivers to states. We see Tennessee building TennCare, moving from a state with one of the highest uninsured rates to one of the lowest overnight as they move their entire Medicaid program into managed care and dramatically expand eligibility. Rhode Island builds Right Care that covers pregnant women and kids, again, much higher incomes. Oklahoma creates the Health Care Authority. Hawaii builds on its old employer mandate and creates the Quest program. State after state is saying, we can do this. And notice these are not the states that you always think of as the ones out front of the pack. So it's not just Massachusetts, it's not just Minnesota, it's not just Washington. It's spreading across the country. Even my old state, of Colorado is commissioned to do the Colorado Care Preliminary Feasibility Study, a report to the General Assembly, commissioned, I might add, by the General Assembly, although they were happy to forget that when we issued the report and they didn't like the contents. Funded, you might note in the bottom there, by the Robert Wood Johnson Foundation, funding a dozen states to develop coverage proposals. I saw Laura Tolan out here. Laura was a partner in crime with me. We were two of the 4 or 5 authors of that report. Those were exciting days. We thought we were going to do this one state at a time, and President Clinton said, well, you don't have to do this one state at a time because I'm going to ask my wife, Hillary Rodham Clinton, to create a task force, and she will build a legislative proposal for the country. And her proposal is going to be built on the thinking that had been done earlier by the Jackson Hole Group. We all got to learn about this very obscure town in Wyoming where these wise people had figured out how to blend competition and regulation and provide coverage to everyone. And working and toiling into the night leads to President Bill Clinton on September 22nd, 1993, 9 months after his inauguration, which was, let's just say, a lot later than he said he would have a bill. He stands in front of a joint session of Congress, holds up a health security card made to look very similar to a Social Security card, and says, we are going to get universal coverage in this country. And as he finishes his speech, he returns to the White House, and Ira Magaziner, who's the person who led the effort to build the law, walks around and hands out to everyone in attendance a health security card, and this is a picture of mine. I still have it. It doesn't provide me with any coverage, I might note. But there are 2 people, Bill, sorry, he's not a pal, I shouldn't call him Bill. There are 2 people President Clinton did not invite to the White House that night, and they are these 2 people.
This was covered under our old plan.
Oh, yeah, that was a good one, wasn't it?
Things are changing, and not all for the better. The government may force us to pick from a few healthcare plans designed by government bureaucrats.
Having choices we don't like is no choice at all.
Yeah, they choose.
We lose.
For reforms that protect what we have, call toll-free. Know the facts. If we let the government choose, we lose. Call today.
I don't think that number is operational anymore. Those were Harry and Louise. You may have heard of them. They helped to bring down the Clinton plan by sowing seeds of doubt about the government getting in between you and your doctor and impeding your choice with respect to health insurance. And indeed, the Health Security Act that was developed over so many months was never even introduced into Congress. No member of Congress adopted it as his or her own. No vote was ever taken. And the backlash against the president is so strong that in 1994 we have the Republican Revolution. And it truly is a monumental shift in the power in this country. 54 House seats, 8 Senate seats shift to the Republican Party. At the state level, 12 governors move over from being Democrat to Republican. The Republicans are a majority of governors for the first time in 20 years. 472 state legislative seats move from Democrat to Republican column, creating a majority of state legislatures with Republican control for the first time in 50 years. It really was a monumental shift. And the key figure leading the national effort is Newt Gingrich with his contract with America, and a key component of it is welfare reform and conversion of the Medicaid program to a block grant. And indeed, Congress passes and sends to President Clinton a welfare reform law that includes conversion of Medicaid to a block grant. President Clinton vetoes that provision twice, in fact, and ultimately Congress does pass welfare reform. They don't change Medicaid into a block grant, enabling us to debate the merits of Medicaid block grants yet again, so many years later. And needless to say, the air is let out of the balloon. The federal government is a complete failure in promoting comprehensive coverage and is now considering major reductions in possible coverage. And states, which had had a big head of steam, the steam is let out is let loose at the state level as well, and state efforts fizzle out. And we see the end of the era of an effort for comprehensive reform. But again, the issues don't go away. In 1996, we get HIPAA, the Health Insurance Portability and Accountability Act. And what's striking about it, you may know it because every time you pick up a medicine at the pharmacy, you have to sign something that they won't release your records, but it's also the federal government's first serious foray into regulating the health insurance market, which we had known was a state purview, but they said, no, you have to make sure that people have portability of coverage, and the federal government will assure that nationally. And it also introduces a concept that's quite familiar now in the Affordable Care Act, which says to states, you do it, but if you don't want to do it, we'll do it. And HIPAA, to this day, there are a few states that do not run their own HIPAA-compliant programs, and the federal government runs it for them. That's 1996. We do ultimately get welfare reform. Way on the left of that picture is Roy Romer, my former boss, governor of Colorado at the time. And this severs the link between welfare and Medicaid. And then in 1997, a major accomplishment of the Clinton administration is the Balanced Budget Act of 1997, with many provisions. Just to remind you, it creates Medicare Plus Choice, starting the use of managed care in Medicare. It expands coverage for people with disabilities who are in the workplace. It creates the sustainable growth rate formula designed to keep cost growth down in Medicare, something that Congress can't leave alone, and year after year they let themselves out of that formula, showing us how effective the federal government is at controlling budgets. It allows states to do mandatory Medicaid enrollment in managed care without a waiver. It increases the amount of wraparound the Medicare program that states have to pay for, another time-honored tradition. But for many of us at the state level, the most notable feature of the BBA is the creation of the SCHIP program, State Children's Health Insurance Program, which builds on 27 states that already had programs in place. Enrollment grows rapidly in the first few years, dramatically bringing down the number of children without health insurance. In 1999, we get the Ticket to Work Act, which expands coverage for people with disabilities. We get the Master Settlement Agreement in the tobacco lawsuit, creating a couple of $100 billion in payments to states, and the Supreme Court rules in the Olmstead case that fundamentally alters the shape of services for people with long-term care needs. So this is the period where we're not doing comprehensive reform, but health care continues to evolve and the federal legal structure and legislative structure continues to evolve. As I said, much of the air was taken out of the balloon at the state level, and as the country moves to the right, California tries to do single payer by ballot, and it is defeated by almost 75 to 25%. Los Angeles County needs a waiver to keep its doors open for access to care, and the Mass Health Program, which is the platform for the later Massachusetts health reforms, come into effect. But really the big story of this era at the state level is the creation and rollout of the CHIP program, a tremendous success, cutting the number of uninsured children in this country from the time of enactment, almost 1 out of 4 poor and low-income children without coverage today. We're down in the single digits in almost every state, in the very low single digits in many. But because of the success of the program and because of the funding of the program, states start using CHIP funds to cover parents, and even a few start using it to cover higher income folks and adults without children, and that leads to some backlash against the program. But this is where much of the state effort is going during that era. Now, there is also a parallel story developing at this time, and it's about quality. In 1990, NCQA is formed. In 91, they develop HEDIS, the measurement set. We see the Institute of Medicine publishing To Err is Human in 2000, a year later crossing the quality chasm, the debate over the Patient's Bill of Rights, and The Institute for Healthcare Improvement is founded in 2004. They create the 100,000 Lives campaign to improve patient safety. And so 10 years after Betsy Lehman dies in Massachusetts as a result of a medical error in the administration of chemotherapy drugs, 10 years later, the nation passes the Patient Safety and Quality Improvement Act. And just a few years after that, Don Berwick, before he is running CMS, coins the concept of the triple aim, balancing population health, the individual experience of care, and per capita costs. States, meanwhile, have been working on the patient-centered medical home, with half the states implementing payment systems to support that. And in 2007, the PCPCC, the Patient-Centered Primary Care Collaborative, is formed. Marcy Nielsen, now the director of that, I know, is here. So we have a quality and delivery system improvement initiative, but let's return to the coverage story. In 2005, George W. Bush is the president. Yes, admit it, you were watching Friends. You take all of me now. Don't even try to dance to that. The uninsured are at 13.5%. National health expenditures continuing to grow as a share of GDP. In 2006, the Deficit Reduction, this is my favorite, in 2006, the Deficit Reduction Act of 2005 is signed into law. It's my favorite. It allows, it facilitates the move of the Medicaid coverage more to look like commercial coverage, allowing cost sharing for many populations. And we finally get Medicare Part D. But one of its most popular provisions for states is the clawback, reminding us that whatever the federal government giveth, it may take away, by saying, oh, we just relieved you of some of your financial burden, and in perpetuity, we expect you to reimburse us for it. In 2007, President Bush vetoes the CHIP program reauthorization twice. And so again, during this period, there's not a lot of federal movement on coverage, and states get back in the act. In 2003, NASHP loses Trish Riley to implement the Dirigo Health Reform Act in Maine, which is the first of the state efforts in this era to try to address coverage, access, and cost. 3 years later, of course, the now famous Massachusetts Health Reform Law is signed, and the Vermont Blueprint for Health is also created. It's worth noting that a year later, California came within inches of passing comprehensive health reforms, and Utah built their health reforms around an individual choice model. So states are doing a lot here. In fact, the concerns about moving forward on health are so large that we also see some local initiatives. We see Healthy San Francisco trying to address the problem of the uninsured. In 2007, Howard County here in Maryland also develops its program. And I am now going to very quickly, because most of you were alive during this, I think it's probably safe to say all of you were alive during this, but if you were too busy watching American Idol, you may not have noticed all the people listening to...
Don't stop, make it pop, DJ blow my speakers up tonight. I'ma fight till we see the sun.
So thank God we finally have some music we can dance to again. The economy, however, is in that rather steep dip, as you all know. The federal government adopts the stimulus legislation, which, among other things, enhances the federal matching rate for the Medicaid program. And we're now in the era of implementation that I'm not going to dwell upon. You all know it well and are living through it. But with the nation now having a framework for coverage for all of its flaws and concerns about it, there is at least a framework, and I would say we're now firmly in the era of attention being paid primarily to cost. And once again, we see the states leading the way. In Massachusetts, Attorney General Martha Coakley releases a report showing tremendous variability in payment rates to hospitals and physicians by the major insurers. In Vermont, once again says we're going to take more control over spending levels in our state. They got a lot of press for thinking about single payer, but there was a lot in that law that had to do with cost. We now, in the last couple of months, you've probably seen a lot of reporting in Arkansas as they bring their efforts at payment reform. And so around the country, we see more attention to cost. And it's driven, of course, by these kinds of graphs that if you go to 2 healthcare conferences, you will see these graphs 10 times. These show us that we are an outlier when it comes to our share of GDP, to purchasing power parity in comparison to our international competitors. It shows us that the future federal budget is completely driven by growth in healthcare spending, and it also shows us that states are basically losing their ability to pay for anything other than healthcare as healthcare costs continue to grow. And that's the tour. So with that breakneck review of 25 years of history, I thought it was time to think about what we've learned from all of this. And I'm going to offer you 5 lessons and then look a little bit into the crystal ball and then let you go. So the first lesson, I can't talk about health policy, can't really talk about anything without talking about federalism. I think the first lesson we have is that federalism is a defining feature of American health policy. What do I mean by that? The baton keeps getting passed back and forth. Sometimes the states lead and the federal government takes it the rest of the way. Sometimes the states lead and the federal government doesn't do a thing. Sometimes the federal government leads and the states follow. Sometimes the federal government leads and the states don't follow. But we're constantly in a dynamic of shifting leadership on these issues back and forth between states and the federal government. And federalism is also key because states really do differ in how they approach these issues. Different ideologies, different markets, different financing structures, different delivery systems. We really are different. And we have spending discipline that the federal government doesn't have, and that's both a blessing and a curse, because it means that we can say no when no is the right answer. But we also say no sometimes when a lot of people go without their needs being met. And so we have a dance about, again, who's going to pay and how much are we willing to pay. And states are impatient, in part because their cost pressures are real. And that's also a blessing and a curse, because we want to move. We don't want to evaluate. We don't want to pause and consider. We want to act. And the federal government and act, although it's in the name of every bill, is a bit of an oxymoron. And, but the final part of this lesson is that we have to acknowledge that without a federal framework, states will go in highly variable directions. And you may feel great about that, or you may feel terrible about it, but at least we should acknowledge it as a fact. In the absence of a federal framework, states will move in quite variable directions. The second lesson, economic cycles really do drive health policy. It's quite striking as you look at our ebbs and flows. Of course, when times are tough, people are more worried about their health, but we don't have the money to do anything about it. And when times get better, we have the money to do something about it, but people say, you know, maybe this isn't so bad, and I'm nervous about losing what I have. And what's striking in the survey literature is that health is almost never a top-tier issue for voters. It's usually a subset of the economy or a subset of views about the role of government. But somehow health as an issue itself doesn't motivate people. It's really economics that drive these cycles. Third, state health policy never sleeps. Now, we could say state health policy makers never sleep because there's so much to do. But it is also the case that although newspapers tend to focus on coverage, and when we're building an exchange or adding people to a program or cutting them off a program, that gets headlines, the reality is there is an undercurrent of activity designed to improve the delivery of care, improve the quality of care, improve the safety of care, improve the organization of care that you all and states work on every day. And one of the best parts of my job is that I get to talk talk about that activity as something that happens all around the country all the time, when nationally people basically think we stop and start because all they're paying attention to is whether coverage is expanding or shrinking. State health policy is active, and it is active at all times. The fourth lesson is that health system improvements are as hard to sustain as they are to attain. Our history is filled with efforts to do things that run into barriers driven by politics or budgets or exhaustion or some other forces that prevent us from sustaining what we do. The political winds shift, the economic cycles turn, and we have to start again. And what we always hope is that it's 2 steps forward, 1 step back, not 1 step forward, 2 steps back, but we get some of the latter as well as the former. It's very hard to sustain our gains. And the final lesson is that health system improvements do not spread like mayonnaise. Now, whether you like mayonnaise or not, it has one feature that's really great about it. You stick the knife in, you put it on the bread, and it's even, and it goes right up to the edges, and it's really easy. But a lot of health policy spread is more like peanut butter. You put it on the bread, you try to spread, it sticks to the knife. You push a little harder, it tears the bread. It ends up on the plate instead of on the bread. We don't really know always how to take our lessons and make them work around the country. Sometimes health policy lessons spread like a pat of butter on the middle of the bread stuck in the microwave, where it just pours all over the place. 25 governors come back from an NGA meeting and all decide simultaneously that we need to do managed care next week. So we don't have the nice controlled mayonnaise texture down in state health policy, and that's the last lesson. So I thought, just to finish up this afternoon, I would gaze into my crystal ball and ask the question, because we are planners here at NASHP if we are nothing else. What is going to be on the conference program 5 years, 10 years, 25 years from now? And I looked in the crystal ball and I found this. Medicaid affordable government, gotta change crystal balls. Maybe it's gonna be a little bit more like this. How much can Medicaid do? How much are we willing to spend? We looked back in the archives and we found a couple of things you might want to see. Less federal funding for Medicaid. Is state flexibility the answer? 1995. Can Medicaid do more with less? 2006. My guess is we are going to be having this discussion about how much we can afford and how much we can do at the state and federal level for a long, long time. So I pulled back out the crystal ball and said, you can do better, can't you? Cost curve straightened. This is not a good crystal ball. I think a more realistic cover to our conference program is balancing market forces and regulation. I just think it is inevitable that we are going to toss back and forth for ideological and practical reasons for many years to try to figure out how do we harness what we know markets can do far better than any government agency, but how do we structure those markets in ways that will make them work? And we even heard, I think, despite the acrimony or the controversy in the presidential debates, we have 2 presidential candidates, both of whom clearly express an interest in balancing. They might have different balance points, but they clearly agree on the notion that you have to harness both of them, and my guess is we will be working on those for a very long time. So I looked back in the crystal ball, and I found. Now, for those of you who live in the greater Washington, D.C. area, you know that this is not going to happen. But maybe we'll have a conference session more like this, taking a regional approach to improving population health and program administration. I think sometime in the next 25 years, we are going to have to confront the fact that states are a kind of awkward unit for everything we do in healthcare, highly variable in size, capacity of all sorts. And as we move more into looking at cost and population health, we are going to realize that half of the major cities in this country are on state borders, and that we can no longer just say state health policy is about one state at a time. So I think you can expect that on a future NASHP conference. I looked I've got only 2 more times. I'm starting to give up on the crystal ball, but it came back with this. Yes, not only are we going to agree on how to pay, but it's going to be a method that all parts of the healthcare sector are going to think, that's exactly the signal I always wanted the payment system to give me. I know how to practice in this environment, and we've perfectly balanced the incentives to transform the delivery system. No, I think a little bit more likely is something like this. We are going to be working through our differences indefinitely. We're going to be trying to improve our payment methods to get better care and more affordable care, and we are going to be doing this for a very, very long time. So I said to the crystal ball, please, one more. And it came back with this. Yes, it would be nice if we could come up with a single national solution to all of our healthcare problems. And we would not just eliminate the need for waivers, but maybe we would even eliminate the need for sitting around and meeting and talking about all this stuff, because we'd solved all of our problems. But indeed, I think it unlikely. I think it is far more likely